Well, thank you so much for joining us today. Really appreciate having you.
Yeah, pleasure to be here.
You want to introduce yourself, name, title, background?
Yes, Duane Smoot. I'm the interim senior vice president of health affairs at Meharry Medical College. My training is in gastroenterology and used to be chair of the Department of Internal Medicine, and then associate dean for clinical affairs, and now vice president of health affairs, and I oversee the Meharry Medical Group.
And with your position in health affairs, you oversee, I guess, research initiatives and all of that. What do you do?
Well, more so running the medical group, the different clinical practices we have. There is some clinical research, so yes, I am involved with clinical research. I have a couple of grants of myself that I oversee, but most of the time is spent running the practices and building the clinic structure for Meharry.
And tell me about that. What services do you guys provide through your practices?
Oh, well, glad you asked. So we have psychiatry, we have internal medicine, family medicine, OBGYN, pediatrics in our practices. We also have general surgery and vascular surgery. And in internal medicine, we have subspecialists in pulmonary critical care, gastroenterology, infectious diseases, endocrinology, and also, who am I missing? Oh, hematology, oncology. Can't forget them.
Yeah, I love how you put everyone in there. What's your patient population look like? What kind of patients are you guys treating?
Well, we're seeing primarily minority, a lot of low-income patients. We see about 25 to 28% of our patients are Medicaid, about 12 to 14% are Medicare. We have maybe about 17% commercial.
Yeah. And of course, we're here today to talk about telehealth. And I know that you guys have been, building up a telehealth program. How have you been deploying it?
Well, we've been trying to deploy that throughout all of the patients that we see. So it's going more robustly with the psychiatry, behavioral medicine. They were doing telemedicine pre-pandemic and really expanded that. So they're doing almost all telemedicine during the pandemic. They're seeing some patients in the clinic, but it's really primarily utilizing the telemedicine platforms that we have. And then our family medicine, our other specialists, subspecialists, even surgery are using the telemedicine.
Yeah, and you noted that you guys had a telehealth program before the pandemic started, but the emergency period really facilitated it, and even probably mandated it for some of your patients that needed to stay home during those early times of the pandemic. What did it look like in 2019 versus what you guys are doing now?
Well, it was primarily with psychiatry in 2019. We were exploring it in the medical practices and family medicine, trying to improve the contact with patients that prevent them from going to the emergency department and post-discharge to make sure we see them if they have trouble coming in to see us. So we were somewhat limited because of the difficulties in getting reimbursements.
And of course, reimbursement opened up, regulations opened up, and sort of helped you deploy this more. But you also received grants to help scale your program. Can you talk about those? Yes.
So we received a large grant from the FCC for over $700,000 to help us with equipment, supplies to roll out to telemedicine to the entire practice.
And what went into that? What supplies did you have to get? What did you add to the program?
We added to the program. We spent a fair amount on additional computers. Some of the systems weren't running very well when we were doing video conferencing. To expand the bandwidth for the school, have a backup line. So if the internet went down, we'd have a backup so that we could maintain the services. In addition, rolling out remote patient monitoring was a big part of what we were looking at, because we not only wanted to be able to speak and see the patients through telemedicine, but we needed to get vital signs, blood pressures, blood glucoses, and so we can give out glucometers to patients, blood pressure cuffs, we can give them thermometers, and also pulse oximeters, which in case there's a concern of them developing getting COVID, then you could check their oxygen saturation. So we were able to purchase a lot of these devices so that we could deploy them to the patients and at no cost to them.
Yeah, and that's so interesting because it's not just the patient at their home calling their doctor. You actually have technology in their home to help monitor their their illness or their vital signs. Right?
Yes, that's correct. Yes.
Yeah. Trying to think what's next. Sorry, I'm totally drawing a blank. How do you integrate what you do at home with monitoring their vital signs with their entire care plan? Because it doesn't replace the care that you guys provide, right? It sort of supplements it. What's your thinking there?
Well, the information that we get from the patients at home comes electronically to our platform. So we can see their vital signs. We can put that in the record. So it makes it more of a regular visit. So that we can then follow through with our care plans, adjust medications as needed because we have their blood pressure readings. And with remote patient monitoring, we really ask them to try to get us readings at least 5 days a week, if not every day, so that we actually get better information than just when they come to the doctor. So we can really see where their blood pressure is. We can really better see what's happening with their blood sugars also.
And what are you going to do with all that data?
Oh, well, it just helps, makes it easy for everyone to counsel the patients on what's happening. If you see a spike in the blood sugar, then you can have that discussion on what happened. And, people eat this or eat that and say, oh, this won't bother your blood sugar. There's no sugar in this pie or something like that. And so it actually gives you a better handle on what's going on. Or patients' blood pressure is high when they come to the doctor. Is it normal during the other periods? So you're seeing it throughout the weeks between the visits and being able to see if the medicine needs to be adjusted or is it just an issue when they come to the physician. So it's very helpful.
And what's the purpose of all of this? Like what did you seek to solve or do with all of this?
Well, a large part of this is try to see what we could do with the health equity gap. And so we're trying to improve health equity. We know that the low-income patients that we see have difficulty in getting to the providers. They're not always the most compliant patients. And we're trying to see what additionally we can do to improve their compliance to help them with their management of their diseases.
And you mentioned it's kind of hard to get the patients to comply with the tools that you give them. Can you talk about that a little bit?
Yes. Well, it's actually still an issue even with the remote patient monitoring. The patients would take their blood pressure readings the first few weeks, and it's still staying in touch with them, contacting them so that they continue for months later to take their blood pressure readings, to do their blood glucose measurements. So it's still an ongoing issue, but with the additional involvement of the patients, we find that we think that we're going to be doing much better.
So there's a lot of probably communication and prodding to get them to put on their monitors and take the readings every day. And
yeah, so they're trying to get more engagement.
And I think another aspect of this that is really interesting about what you guys are doing is that you actually provided hotspots to some of your patients that wouldn't have otherwise been able to use all of these tools if you hadn't. And it's sort of that digital divide that it's blocking accessibility from this technology. But you guys seek to solve that.
Yes, so that has been one of the things, having the funding has been allowed us to get the devices. And if a person has a smartphone with Bluetooth technology, if not, we can get a hotspot so that we can get those readings electronically to our electronic record and be able to monitor the patients.
And how many patients are you guys monitoring right now?
We're monitoring close to 100 patients right now.
Yeah.
Mostly Medicare, but we're starting these last few months with the Medicaid patients.
And is this type of thing scalable? Like, could it be the entire Medicaid program one day?
It would be nice, but I think it would be a large proportion. The difficulty we've seen with the Medicare patients that are more senior elderly, again, they're not that interested in learning more about the phones and in downloading apps. So we haven't been as successful as we thought we would have been with the Medicare population that we see. But we're doing a little bit better starting out now with Medicaid patients. And we have a lot of young patients on Medicaid that have chronic diseases, that have very difficult to control blood pressure. So they don't have an issue with the technology. It's just getting them to agree that it's important to engage and monitor this to prevent the complications later on.
And of course, all of this is happening because we have an emergency period that we've talked about is taken regulations from the past away, and insurers are reimbursing for these services. But do you think that you'd be able to provide these now outside of the emergency period?
Well, that's going to be the big question, yes. And we're hoping that the reimbursements will continue. Right now, part of the difficulty is the reimbursements for Medicaid, for chronic care management or remote patient monitoring are minimal, so that it really doesn't cover your costs.
So you're sort of just waiting to see what's going to happen.
Yes, and still moving forward with the expectation that the payments will continue, but they would also increase because we do need to reach out to the patients. It takes time to go through the information on setting them up, doing their visits so that they're ready to use the technology when they get home. And so, so it does take staff time and effort to move these along.
Yeah, absolutely. Well, and I guess my last question is, what's your biggest takeaway from this initiative, and how do you see telehealth being applied in the future, especially with this focus on, the Medicaid, Medicare populations? What are your thoughts?
Difficulty, a little more difficulty than I thought with the engagement. We have those patients that are very much interested in their health. They are very interested in having the devices, monitoring what they do. But as we know, a large portion of the population that have the chronic medical illnesses are not that engaged. So we now have a way to engage them, and now part of that is being able to present this to them in a way that they can see the advantage and then their interest and the time that it takes to learn it so that they can then do this going forward. And, a lot of the problems with heart disease, chronic kidney disease can be prevented if we can monitor these earlier on, reducing blood pressures, monitoring blood sugars. So we're hoping to educate the patients so that they will come along with us and be able to reduce these long-term complications that we're seeing, especially in the low-income and minority communities.
Yeah, well, and it sounds like you're trying to initiate like a lifestyle change, which kind of gets into, I know Meharry studies this extensively, but social determinants of health largely, and having holistic care and, preventative.
Yes, that's very, very, very much the case.
Yeah.
So we're looking at social determinants. We're patient-centered medical home. We're looking at the quality measures, including social determinants. And so, yes, this is now a new part of the armamentarium that we have to improve these measures in our patients.
Great. Awesome. Well, thank you so much for being here and sharing your insights. It's great to have you. Thank you so much.
Oh, well, thanks for the invitation.